Hi, I'm Larry Bauer. I'm a social worker by training and one of the founding board members of Primary Care for All Americans. Before I begin, I do want to take just a moment to acknowledge that we lost a colleague this week in Alex Pretty in Minneapolis, uh, something that was more than unfortunate, and we just wanted to acknowledge that. So, a little more about me. I founded and led the Family Medicine Education Consortium from 1994 to 2021. Additionally, I'm a proud member, as I said, of the founding board of the Primary Care for All Americans. On behalf of the board, I'm pleased to welcome you to tonight's Teach In, Learn In Zoom session. Thank you for joining us this evening. With over 1,600 people from 40 states and the District of Columbia, with 350 zip codes included in our membership, we are reminded of the incredible momentum we are building together to provide primary care to every American neighborhood and community. Thank you for your dedication and commitment to expanding access to primary care across the country. Now it's my great pleasure to introduce our moderator for this evening, Dolly Ojo, and to extend my sincere thanks to all the presenters for tonight's event. I'd also like to thank the Primary Care for All Americans Zoom committee, as well as John Wright, Patty Armstrong, and Liv Veraday for organizing this event. Take it away, Dolly.
Hi, everyone. I'm Dolly Ojo, family medicine resident at St. John's Episcopal Hospital in Far Rockaway, Queens, New York. I'll start by thanking you all for being here tonight. By joining us, you're helping to build a movement, one that focuses on providing healthcare to people in every neighborhood and community. Primary care for all Americans. Don't forget to add your name and location in the chat. As a quick reminder, we don't use professional titles here. This space is about working together and valuing the ideas and commitments that will drive this movement forward. Now, it's my great pleasure to introduce our keynote speaker, Marguerite Duane. Dr. Marguerite Duane is a board certified family physician practicing direct primary care house calls in the DC area. While she provides the full range of services to patients of all ages, she specializes in root cause reproductive medicine and cares for females from adolescence through menopause. Dr. Duane is the co-founder and executive director of Facts About Fertility and serves as an associate professor at Georgetown and Duquesne universities. She has also served on the boards of the American Academy of Family Physicians and the Family Medicine Education Consortium. Take it away, Marguerite.
Thank you so very much, Dolly. And thank you to all of you for inviting me to join tonight. I'm really delighted to be here to share more about my work as a direct primary care physician through my practice called MD for Life. The title of tonight's talk is Caring for Patients in the Comfort of Their Own Home. And I'm really especially delighted to be joined tonight by a couple of my patients, and I'll give them a few minutes to introduce themselves in just a little bit here so you can hear from the patients for whom I care for. Dolly did a great job introducing me, and I appreciate that. And I do want to just really acknowledge the people that make my work possible, my family. First and foremost, my husband and fellow family physician, Dr. Kenny Lynn, who is a wonderful supporter, I know, of primary care for all. We are incredibly fortunate to have four beautiful children who really give me meaning in my work. And I'm so grateful for my children. Um, I found my call to medicine really through my mother, who served as an incredible role model for me as a nurse, and her love and compassion and care for people really motivated me in my work. But most importantly, it was witnessing the birth of my baby sister at home when I was just 8 years old That was the day that I decided I would be a doctor. On November 2nd, 1979, sitting at my mother's feet in our home and watching my baby sister being born into this world. As you can see, I'm one of seven children, and I think it's just profoundly amazing that now, 40 plus years later, my practice is all around, centered around caring for people in their home and in particular, helping families to grow by having children. Again, I'm ecstatic to be a family physician and I'm very proud of that title. I started doing direct primary care 10 years ago, this very month in January of 2016. I joined a fellow family physician, Dr. Matt Hayden, to start Modern Mobile Medicine. And about 3 years ago, when my family relocated to Lancaster, Pennsylvania, I formed my own direct primary care practice, MD for Life. What was amazing about that is in 2022, when I moved from DC to Lancaster, I had 130 patients. And I informed all of my patients that I would be leaving to move to Lancaster and offered them the opportunity to stay with me. And 112 chose to continue with me, despite the fact that I was going to be 2 hours away, but really happy to be able to do that. Another role that I hold very near and dear to my heart is as a teacher through my role at Georgetown and at Duquesne. And as you'll see throughout the pictures, my life is very intertwined. The patients that I care for, the students that I teach, and the work that I do through my nonprofit, Facts About Fertility. And I just really want to take a moment and recognize Larry Bauer, who's been an critical part of primary care physicians for all. Larry is the reason that we were able to form Facts under the umbrella of the FMEC, and I'm just so incredibly grateful to him for all of his support over the years. It's been incredible. So thank you, Larry, as always, for your incredible support. So with that, for tonight, I really want to just highlight some key points that I want to make sure to cover. These are the objectives, but really this is going to be a picture through stories. I will talk about what are the key features of a direct primary care practice, how it is distinguished from concierge medicine, and really the unique features of a house calls based practice. I'm going to identify the wide range of family medicine services that can be provided by a solo family physician in the home. Now, in spirit of full transparency, I was very fortunate to add another physician to my practice last year. She works in very, very part-time and also works doing entirely house calls based medicine, and really highlight how direct primary care allows physicians to integrate their areas of interest or specialty care into their practice. My colleague, Dr. Walsh, is a DO, and she's able to integrate OMT into her care. My passion lies in women's health and fertility, and I've been able to integrate that into my care. Really, direct primary care gives you so much flexibility. And I'll end by talking about some of the benefits and challenges of a DPC model and a house calls based practice. And this may be where I'll invite some of my patients to share from their perspective. So, what is direct primary care? I realize many of you may be familiar with the term, but some it may be new. Direct primary care involves working directly for your patients, providing primary care services, preventive health, chronic care directly for your patients through an agreement and typically a monthly fee or fee for service. Again, it is typically a monthly fee. It's payer agnostic. I work from a patient. They're the people that I respond to. I don't work for the government or the health insurance companies. We do not do fee for service billing, and this is a real distinction with concierge medicine. Concierge medicine will often bill an ongoing fee, whether it's a monthly or an annual fee, and that's really to provide access. And concierge practices will often still times bill insurance companies, but in direct primary care, we do not. We are actually providing healthcare. It is not health insurance. And it's very exciting because just this month now, with the passage of the legislation last year, patients can now use their healthcare savings account to pay for direct primary care. Prior to this, the IRS prohibited that, but this has really been a huge boon for some of our patients. So we're really excited that that is a possibility. So in terms of a house calls micro practice and how this differs, with the house calls based practice, one of the best things is there's very limited overhead. I started my practice in 2016 when my youngest child was just a year and a half. And at that point, I really was focusing my work growing the Facts About Fertility Collaborative Project under the FMEC, but I had stopped clinical medicine 4 years earlier to focus on my family. That being said, I was very interested in returning to clinical care, but did not want to do it at the expense of leaving my children. By doing house calls, it allowed me to slowly grow my practice because I didn't have to worry about rent or minimal staff, so the expenses were very limited. It really does improve continuity of care, especially for patients who have difficulty getting to the office. And oftentimes people think the people that are having trouble getting to the office are the elderly. But the truth is I can actually count on one hand the number of patients I have that are over the age of 65. The people that oftentimes are challenged are people with large families, people with young children, people that may rely on public transportation, and being able to provide house calls can provide a huge boon for them. Doing house calls as well as with direct primary gives you more time with patients. And I think that leads to better care and improved satisfaction. And when you're able to see patients in their home, you don't have to ask about the social determinants of health. You see it. I'll oftentimes open the refrigerator, put the vaccines in the refrigerator that I brought with me, and I can see, is there an issue of food scarcity? I can get a sense just by walking in the home, like, are there safety issues that we need to be addressing? One time I had a patient call me because he was having knee pain, and I had just left to drive my younger children to school. And he's like, do you think you could stop by? And I said, well, I could run home and grab my computer after dropping my children off, or I could stop by on the way back. And he's like, well, if I didn't mind stopping by on the way back. And I said, sure. And as I was examining him and saw him in his house, he said, well, where did you fall? He's like, I fell, I was walking down the steps to my basement. I said, well, show me the steps to your basement. And in doing so, I noticed that he didn't have a railing on the lower half of his step. And he was also a diabetic. And I said, the most important recommendation I can make for you is to call a handyman or carpenter to get a railing installed on the stairs, because that's likely going to be the biggest threat to your health. Direct primary care, and I think in particular house calls-based practice, also leads to improved doctor-patient caregiver relationships, leading to increased physician satisfaction. Again, when I started my new practice, MD for Life, I chose that name because as a family physician, I care for patients at every stage of life, from newborn to beyond, to old age and beyond. But my commitment to my patients is I will be their doctor as long as I'm alive or as long as they're alive, because as long as they're willing to continue to, pay me for my services, I'm happy to continue to care for them. That being said, sometimes patients can't always pay for services. With the government shutdowns in recent years, taking care of patients in DC, I've had patients that have been out of work, and I'm able to simply suspend their payment for a few months just to give them the time that they need to be able to continue with the services. I also feel like doing house calls really improves end-of-life care, and I'll speak to that very specifically with one of my young patients who unfortunately I had to diagnose with cancer and cared for him in the last 14 months of his life. And as a micro practice, we really are able to leverage technology to increase efficiencies and reduce cost of care. It's interesting because I started doing house calls in telemedicine in 2016, long before the pandemic. So I used to joke, like, I was doing Zoom calls and telemedicine long before it was the cool thing to do, if you will. So I want to switch now to really talking about direct primary care as a family physician. I absolutely love doing family medicine because I love caring for patients at every phase and stage of life. When you're able to do direct primary care, I really can focus on the family. I'm able to provide full spectrum care. I'm able to provide the follow through the patient's need. I can make the practice really for the patients, and as I said, for life and for the future, as you'll see how I integrate teaching into my practice. So here's an example of one family. I mentioned earlier that I had a patient who I diagnosed with cancer and saw him through the care of his cancer. I diagnosed him with cancer when his wife, pictured here, was pregnant with their seventh child. This picture was taken about a month after his death. And what was so beautiful about this picture is this wasn't about me going to see them. It was them coming to be with me and with my daughter when she made her first communion. The relationships I'm able to form with my family to be able to celebrate both the good times and the difficult times has been so incredibly rewarding. This is a picture of my son who is a sophomore in college. As a high school student, he would often accompany me on my house calls, learning how to do basic vitals. And oftentimes, when I would show up at patients' homes, they'd be like, "Where's Isaac?" or "Where's Eden?" Asking for my children because they would always love to see them. And I think this really sets an example of a role model of how we can truly care for patients and care for families. I do full spectrum care, and I am able to do that in the home. So here I'm doing hearing screenings for a young boy in the home. I'm able to provide vaccines in the home. I simply order them through my local pharmacy, pick them up on my way to the house call. I'm going to administer while I'm there. I'm very excited about the fact that I do newborn care. Again, in family medicine, we oftentimes will say we care for patients from cradle to grave, and here I am holding one of the many newborns that I care for. We say cradle to grave. Sometimes we say for care for patients from womb to tomb. As a family physician who actually specializes in infertility, I like to say that I care for patients from lust to dust. So even before they've conceived, working with them to help them achieve their goal of having a newborn. I also do acute care. I love this picture because here I am in my Wonder Woman outfit. That's not my usual outfit that I go out doing house calls in, but this was Halloween and I was out trick-or-treating with my children when I had gotten a text from one of my patients whose son, over exuberantly looking forward to eating his Halloween candy, ran a little too fast and fell and cut his head open. So I was able to go over and to address that and thanks to the beautiful work of Dermapon, was able to successfully close that laceration all in my Wonder Woman outfit. Again, given my interest and passion in women's health, I am able to do ultrasound. I'm very fortunate to have a colleague, a former colleague of mine who I worked with at a community health center. She runs a pro bono clinic for the poor, providing some specialty services, including physical therapy, eye exams, and ultrasound. So I'm able to use her ultrasound as needed for my prenatal patients. I've also been able to take the ultrasound machine with me, and that's actually been really helpful. There have been times when I've had to diagnose a woman with miscarriage, and being able to do that in the comfort of their own home is so much better than in the cold setting of a radiology center. And then, of course, follow up. I love this picture because here I am caring for a couple as they're working towards growing their family. And again, being able to do so in the comfort of their home just makes things so much easier. As I said, I do full spectrum care, really focusing on addressing the root causes, using the female cycle chart as a fifth vital sign that the American College of Obstetricians and Gynecologists notes. When women chart their cycle, we can use this to identify possible risk factors for infertility. In this case, this woman has very limited cervical mucus, which would suggest she might have some difficulty getting pregnant. We were able to address that, and as you can see, a lot more fertile days. Also, we addressed the male factor. In this case, this male husband had a poor semen analysis, but we were able to address that, and they were able to successfully conceive. I do provide chronic care services, our common family medicine care, diabetes and hypertension, depression, the wide range of chronic health care services that we often provide. Mental health care. That's a real interest of mine. I have patients with a wide range of mental health conditions that I provide not only their primary care, but sometimes also support their mental health care or collaborate with psychiatrists. I had one young boy who has serious psychological issues, and I accompanied him and his mother once with their visit to a psychiatrist. And I remember sitting there in with my patient and his mom, and the psychiatric resident kept asking me, like, who are you exactly? And I'm like, I'm his family doctor. I said, and long after you're gone, I will be caring for him. And so I want to make sure I understand and explain and support and provide that ongoing care. And then, of course, end of life care. And I'll get into that story of my patient in a little bit more detail in this next slide. Follow through. I love this patient. This is one of my patients. They currently have the record for living the farthest from me. He actually works for the State Department. I've cared for him and his family while they lived in the DC, Maryland area, as well as when they have lived overseas, both in Africa and South America. Certainly, they're able to access care through the State Department when they're overseas. But just this week, I was communicating with his wife, getting records updated for their next transfer. So really being able to follow through is incredible. And that happens with other patients. So this is my patient on the day that I did diagnose him with cancer. Again, my son participating in his care. And I cared for him for the next 14 months and cared for his children. And as you can imagine, this was quite a difficult diagnosis, especially because it came right in the midst of the pandemic. And I will tell you, as much as I thoroughly enjoy the opportunity to help couples grow their family, to care for newborns, and to witness the birth of a baby, being there for a patient and accompanying his family during the dying process is so incredibly beautiful. I actually spent the last 20 of this man's 24 hours of life with him and his family. And the next morning, after he had passed, his oldest daughter asked his mom, "Mommy, will Dr. Duane still be our doctor?" And his wife said to their oldest daughter, "Honey, Dr. Duane will always be our doctor." And that's the beauty about doing direct primary care and family medicine. It's not only caring for the medical needs of my patients and the mental health care needs, but it's really advocating for them as well. This first patient was one of my patients who I got a call from her as I was driving home from picking up my children at school. And since I had my kids in the car and I was driving, I thought, well, I'll just not answer the call and call her when I get home in a few minutes. And so I let the call go to voicemail. And then 30 seconds later, her husband called. And I thought, he never calls. So I wisely picked up the phone. He's like, "Dr. Duane, we're here for our 20-week ultrasound, and the radiologist would like to speak with you." Now, if you've ever provided prenatal care, radiologists don't want to speak with you unless there's something seriously wrong. And in this case, she had actually looked like she was imminent for going into preterm labor. We were able to get her admitted, and I was able to advocate for her. I actually drove 2 hours from Lancaster to DC the day or two after she was admitted to continue to advocate that she was able to get the care she needed. She went on to carried the baby for 6 more weeks and delivered preterm, but now has a healthy young daughter due to the advocacy work. Advocating for specialty care. This is a young boy that had some eye issues. I was able to talk to the ophthalmologist and get the care that they needed in a timely fashion. Emergency care. This is little girl was one of the daughters of my patient who had died of cancer, and this was about a month after he had passed away. She had fallen and was holding her arm very gingerly, and the neighbor had to take her in, and I was able to talk to the doctors in the emergency room, got her bypassed from the ER right into radiology to get the X-ray and get the splinting that she needed. So it's really just being able to care for and advocate for my patients is really, to me, I think, a critical role. Again, my practice is MD for life. There's no greater joy than helping couples to achieve their goal of creating new life, to be able to do the ultrasound, to see that heartbeat, and to see the birth of their new baby. But there's also no greater joy than being with a patient, accompanying them through the death, the dying and process and death and the funeral. So much. And then the future. I love this. These are just some of the many students that I've had the opportunity to teach through my work, teaching them how to do eye exams and examine babies. I'm doing well woman care. This is a picture of a high school student with one of my medical students learning how to take vitals. So just, I truly believe in, as doctors, the word doctor comes from the Latin docere, which means to teach. And I think teaching is so essential to what we do. And I'm committed to ensuring that the next generation of medical students have the opportunity to learn to provide full spectrum care. Here's one patient's comments, but what I'd love to be able to do is to, I know a couple of my patients said that they were going to join. So I would love to invite Leah, Leah, if she could join, and then Eric, if they wanted to just join, just to share a few words about their experience. So.
Hello, my name is Leah Madrasina, and Dr. Duane, is this okay time to
Yep, perfect.
check in? Okay. So we've been with Dr. Duane. We actually joined with Dr. Duane's practice when she was still, I think, in Utah
Yeah.
on a fellowship, because I met her, and then also, through talking with some other friends of mine who have also had her as their and still have her as her primary care physician. She had glowing reviews, and I was like, "You have a doctor come to your house?" And yeah, at the time we had 3 children, so we now have 5, um, and it's it's really just been such a blessing to be able to have. If I have a sick child, I don't have to take 5 children all with me to the doctor's office. I can have the baby and the toddler napping while the others get their well child checks. Um, and through through the time we've been with Dr. Duane, we've had various health insurance, no health insurance, health shares. And I told my husband, I was like, we can never get rid of Dr. Duane. That's, depending, you can come what may with the insurance, but she's worth her weight in gold. And that was just underscored with seeing friends of ours, the patient she had mentioned who had died of cancer, just walking with them through all of that. And so yes,
Yeah.
Dr. Duane will be our doctor as long as she will
And
have us.
absolutely. And, the beautiful thing too is, I've been very blessed again having my partner, Dr. Walsh, join my
Mhm.
practice. And with her specialty in OMT, I know she's been able to help provide care to Leah's husband that I'm not
Mhm.
trained to
Yes.
care. And so I'm very excited that we're able to grow the practice in that regard. So yeah.
Yes. So that's been a great help too.
Thanks.
So
And thanks, Leah, for pointing out. I forgot to tell everybody this. We started the practice in 2016, and then during the pandemic, I had a bit of a midlife crisis and thought it would be a great idea to move my family of 6 from Washington, D.C. to Utah to do a research fellowship. And before I left to go to Utah, I had 100 patients in my practice. And I had given all of my patients the opportunity to switch to my partner for the year because he was going to continue to be in the DC metropolitan area, or they could suspend their membership and not pay the monthly fee every month with the option to just rejoin when I came back without having to pay a registration fee again. Or they could continue on as my patient and pay the monthly fee, even though I was going to be 2,000 miles away. And of the 100 patients that I had, 90 of them stayed with me. And then I had people like Leah that I met when I, was home for a visit who was like, how soon can we sign up when you come home? So,
yeah.
which has been great. But Leah, thank you. I know Eric is here. Eric and his beautiful family have been my patients for a very long time. So, Eric, thank you so much for joining as well.
Yeah, thanks for inviting us. Yeah. So my experience with Dr. Duane, or my family and I, our experience, I think I remember the very first day um that I met Dr. Duane. We had our second daughter was vomiting violently, the night before, and I was introducing my family to Little House on the Prairie and telling them we have a Dr. Baker, we have a Dr. Baker of our own, and it's Dr. Duane. And really, I mean, everything that she's been talking about is 100% true. Um, you know, just the care that she gives to our family, just things that you just don't hear about with any other regular practice. People talk about, waiting forever in a waiting room to see a doctor for 10 minutes and, all of that. But man, the time that she spends with our family is really impressive. And just her manner, like I remember, one of the vaccines that I think my oldest daughter was getting, and just trying to talk to her. But Dr. Duane, if you haven't figured it out, I mean, she's talking about people and coming to her daughter's first communion. Her faith means a lot to her, and just to have a doctor who doesn't mind sitting down and praying with your own child, as they're taking a a vaccine, just things like that, and even the teaching aspect. I remember some years ago she recommended these books for my girls,
The
and
Ultimate Girls Body
the
Book.
ultimate girl spot. Let me tell you, my wife reads, has gone through those books with my daughters twice, and I mean, just everywhere, all around, in every case, you know, um, it's just nobody even close, that I've met or known, like Dr. Duane. One night, it was a Saturday night. I don't know where she was. I know she wasn't around,
Most
but I
people
happened
don't know where I am most nights, even my husband. So
yeah, but I just texted her, it was like, hey, we have this. I can't remember what it was, but she called me within 20 minutes, and she was out of town with her family somewhere, but walked us through what we needed. I remember during COVID, when it got real bad for our family, she told us exactly the stuff that we needed to get that would help the symptoms. I mean, you know, we just recently had a child. I mean, our youngest is not quite a year and a half, going on a year and a half, and just days after he was born, she came right down. Like she was over there in Northeast DC, like it's nothing. She's just driving down to to see our newborn, and
I remember that. I remember holding your 1 week baby boy, like looking at this little teeny tiny baby and thinking, wow, next week I'm taking my baby boy off to college. Like I remember saying, don't blink, Eric, because it goes so
that's right.
fast.
That's right.
So
That's right. That's right.
and I just want to say too, like it really is a two-way street. Like, yes, I care for my patients, but they care for me. Like I show up and like there's not a time I haven't shown up to Leah's house. She's like, can I get you a cup of coffee? Can I get you a drink? Eric and his wife, but I remember it was one of my trips back to Utah. They gave me a beautiful book. It was a mother-son like devotional companion because my son was going to be driving back to Utah, and I was like, what a thoughtful gift, you know? So it really gave me and my son the opportunity to bond and it's just it to me it is a little house on the prairie, right? Like I was talking with my nurse today and I'm very blessed, like I've been able to add a nurse to my team, Emily, and she has been incredible. But I was saying to her, like, I don't have a website. If you go on your computer right now and look up MD for Life, you won't find a website. I have one that's kind of been built, but I haven't publicized it because I'm like, I don't need any more patients. I have a waiting list. But my patients have all come from word of mouth, right? Like, there's this community in Maryland, like, I know where everybody lives because I've seen half of them at one point or another. But it's because, as much as I care for my patients, they care for me, and there is no greater joy than caring for Eric and Nana and their beautiful family and Leah and her family and the 150 patients that we care for through MD for Life, whether it's medical care, whether it's sharing a book like The Ultimate Girl's Body Book, which is, Larry, you'll love this, authored by a family physician, two family physicians, in fact, including Dr. Amaryllis Sanchez Woliver, who is one of my colleagues with Facts About Fertility. So there's so much that we can do to care for one another, and I would love to be able to create an army of future family physicians that really, I left DC, but my patient said, you can leave, you just can't leave us. And that's what I did. Like I live in Lancaster. I can count on one hand the number of patients I have in Pennsylvania because they're like, you can leave us, you can't leave us. You can leave the city, but you can't leave us. So I go back and I love it and it's worth it. Because it is really about that relationship. So yeah, I think I covered all of, the benefits and challenges, the freedom, the autonomy, the time to spend with patients, time to research conditions, renewing that relationship. The challenges, for a while I was on my own, but I'm so excited now to have colleagues. The irregular schedule, yeah, patients text on a Saturday evening. Although I've had to tell patients, you should have texted me about that earlier. And they're like, I didn't want to bother. I know other direct primary care doctors or people think you may have trouble recruiting patients. Really, with my specialty in fertility and restorative reproductive medicine, I've really been able, again, I have a waiting list of patients. And I think the other challenge is there's often this perceived need for health insurance. To be very, very clear, I do tell people, you do need health insurance for the things that health insurance is designed for, those unexpected catas catastrophic costs. But for the common things, I'm gonna try and stop sharing so I can get back to you. The primary care, I mean, that is really something that can be paid through a direct model of care. And like I said, I think the best way to do it is in the comfort of the home of the patient. So thank you again, Leah and Eric, for sharing.
Thank you, Marguerite, for everything that you were sharing with us as well. I'm a mom, as you can see. My little one has decided not to go to bed tonight. I'm ready to move down and add myself to your patient list pretty soon. I loved hearing what you said. I wrote down the book for to take a look at, and just have such an appreciation for the fact that you do fertility care. Both my kids are IVF babies, and part of the reason why I relocated to Massachusetts was there just wasn't great care down at the time that I needed it in that area. But thank you for putting that in the chat. Speaking of the chat, we have the chat open. If you have a question or something that you would like to ask Marguerite, please put it in there. We will get it over to you and start this conversation up. One question that I do have for you, you did such a beautiful job of covering all these different facets, including the benefits and some of the struggles. Can you do a little bit of information around panel size, workload, and the economics of what you do?
Yeah, I think that's a great, great question. So what I teach medical students, what I explain to the students who often ask questions, with direct primary care, a full-time physician panel is expected to be about 500 to 600 patients. When I started my practice, my goal was always to do this 20% time because of the fact that I run FACS as a nonprofit. That's a full-time job. And a year and a half ago, I started a new role as a professor at Duquesne University. So for me, my direct primary care practice was always supposed to be part-time. It was always supposed to be 20% time. So my goal was to have 100 to 120 patients. Like I mentioned, between my partner and I, we have 150. I've got about 135 patients. She has 15 because she's a 3-year-old and a 1-year-old and really wants to fully focus on being a mom. So she's just got a few patients. So I have about 135 patients, but I joke, I started my direct primary care practice to really subsidize my habit of running a nonprofit. When we started our practice, it was $89 a month for an individual, $199 a month for a family. I think we were 169 for restorative reproductive medicine. So that was 10 years ago. Now, obviously, we've increased our prices. It's $125 a month for an individual and about $300 a month for a family. But I think for a lot of people, they are able to find it affordable. And for me personally, again, doing house calls, not having rent, that has been a game changer in limiting my expenses. And I feel like I've made more money as a direct primary care doctor than obviously working in an FQHC or even frankly as a faculty member. But the funny thing is it doesn't even feel like work. I mean, it feels like I'm going to visit with friends, right? Like, I have some families that I go to one person's house. One of the first times I met Leah was when I was going to my patient's house who had cancer, and there were a group of them outside, holding a prayer vigil. And to be able to walk into the house and to see my other patients outside. But like I'll go to one person's house and my other patients will come out because they'll see my van and they'll be, it's Dr. Duane, it's Dr. Duane. And that just happened last week. And it was really, really exciting. So yeah. So panel size, typically 500 to 600. Again, I do this very part-time and for a while I didn't make any money running FACS, so this was my only source of income and but definitely manageable. So great question.
Yeah, absolutely. And I see someone in the chat has added, can Medicare B patients be part of
Yeah, so
the DPC?
yeah, so that is a great question. So, like I said, the majority of my patients are actually under the age of 21. I can count on one hand the number of patients that I have that are Medicare age. Yes, they can be. I just can't bill Medicare, and I had to opt out of Medicare. So they need to know, like, I cannot bill Medicare. They do still pay out of pocket. One of my Medicare patients is a religious, so they've taken a vow of poverty. And so their income is less. So we actually have a few religious, and so we offer a religious rate. But the beautiful thing about being a direct primary care practice is you don't. I can change my rates as needed. Like I said, I had a patient, middle-aged man, had a good job, government shutdown, laid off, was out of work. He's like, I can't afford to be your patient anymore. I'm like, you have a history of a cabbage, you have high blood pressure, you have diabetes. You can't afford not to be my patient, right? So like, what's reasonable for you? Like, what can you manage right now? Like, I can't in good conscience not care for them. So yes, they can, and patients with Medicare can be patients. We just can't bill Medicare. So
Okay.
I see a couple other questions. George asked, what do you think the future of DPC at the home will look like in the future, with all the digital virtual tools, AI analytics coming online? I mean, again, I've been able to do so much in the home. There are now tools like and I've trialed this with some of my patients where they can look in the ear and I can get the image like on my phone with an app. I'm like, this is so cool. I can be 2 hours away and look in a patient's ear. So there's lots of things like that are coming out. So that's exciting. Cam
I
asked,
was going to say if Cam, it's actually, I was looking back up here, Cam, which is actually Claudia McNeil. Do you want to come off of mute if you're able and ask your question directly? Are you right there still, Claudia?
while she's coming on, I'll answer Pat's question about managing getting lab works. So we've negotiated with LabCorp to get labs at cost, and I will send patients to a local LabCorp. There is a nurse in the community that I will sometimes contract with if we need to have a nurse go to the patient's home to draw the blood, and then they'll drop that off at LabCorp. Some of my patients will use their traditional insurance to bill their labs to their insurance. Some patients will still bill through our direct bill rate because it's actually less expensive a lot of times. So, do you want me to
Yeah.
answer Cam's question?
Yeah, I'd love to. Part of my question is that I was seeing that she was from a small town in our area that's got a more senior population in it, in Little Compton, Rhode Island. So a little curious about the baseline of the question. But yeah, when a patient's been diagnosed with cancer, as you talked about with the one patient that you have, do you send them to a specialty like the oncologist, or
Absolutely.
how do you sort of track that through?
One of the most important things I tell my students is you need to know what you know and know what you don't know. And when you don't know something, know where to ask for help. So with my patient with cancer, he had been having back pain and neck pain and but enough that I was like, let's just get some labs. And I got his white count, his complete blood cell count and his levels, all of his levels were uh, you know, completely abnormal. And, like a good doctor, I was like, well, let's just repeat the labs and make sure this isn't an anomaly. And I got the repeat labs and they were equally as bad. And I'm like, well, I cannot manage cancer. I can't even necessarily diagnose this type of cancer. So what do I need to do? So at that point, I actually got on the phone and called and was able to schedule this patient with an oncologist before I'd even given him the diagnosis. And I knew he was going to need a bone marrow biopsy. I explained to the office, do not call the patient because I don't want him getting a call from my cancer doctor, like without the diagnosis, but I was able to get him set up with the appointment. But this is why patients do still need, health insurance, right? That is the catastrophic, right? The unexpected. A young, healthy 34-year-old father of six is not expecting to get a cancer diagnosis, right? And he saw all kinds of specialists in DC, in Philadelphia. But ultimately, I cared for him at every step along the way and cared for his family. So yeah, I absolutely, I mean, I played a critical role. I mean, again, he was sick during the pandemic, so in order for his wife to be able to be with him, like she'd have to do a COVID test every day, and I would have to like verify and send a note to be able to allow her to go in and be with her dying husband. So it's not just about caring for the disease, it's caring for the person.
Yeah, and that's so evident throughout your entire presentation, how involved you are in this, in your community. And so thank you for coming and sharing that with our community. We hope you are going to be joining our community and creating more doctors just like you throughout across the United States, because that's what we need to bring primary care to each and every corner.
And I think what doctors will find, like, it really is so rewarding, right? I mean, it's exhausting sometimes. I mean, again, with my patient, who was dying of cancer, like I was up all night with him and his wife, and I'm like, oh, it's like being on call. The good news is I don't have to do this every 3 nights. But to be able to be there at such that pivotal point was so, so critically important. So, um, David, I see had a question about my feelings about concierge docs versus direct primary care. I've noticed such a wide variety of concierge docs who seem almost identical to direct primary care. I think that's true. I mean, I think a lot of concierge docs probably market them as such. I think it's just important to know how, like, what's happening with the billing, right? I mean, as a direct primary care doctor, my fees are probably higher than average. I can say for certainty that my monthly fees are higher than the average direct primary care doc. Part of that is the market in which I work, right, in DC, and part of it is now I have to drive 2 hours a couple times a month to see patients. So, to balance that. But the key is like we do not require insurance to bill for services, which many concierge doctors do. And I think, again, the differences in the pricing, like concierge doctors do tend to have higher practice or higher pricing. I just think with
Absolutely. Yeah.
anything, just transparency and full informed consent, right? Like I never order a lab for a patient or I never have a patient sign up for a practice unless they know, like, if you're signing up, this is the expectation. So,
Absolutely. Well, I'm going to pitch it over to Dr. Michael Fine to tell us a little bit more about what's coming up next and going on in our PC4AA community. Michael?
thank you.
Thanks, Marguerite. And thanks, Patty and Dorothy, for being such good cheerleaders. Marguerite, you really are a pioneer and really a primary care hero of the first order.
Thank you.
It's an honor to know you and a thrill to have you with us tonight. There are 100 different ways for communities to provide primary care to everyone in every neighborhood and community. You've just heard how Marguerite does it, but not even Marguerite can do this alone. It takes a community. It takes an army, as Marguerite said, of, of, of primary care doctors and primary care clinicians working together. We need everybody to step up, so we're training the primary care clinicians of the future from our communities, so we can be building scholarships to help the young people from our communities be able to afford primary care training, so that people without insurance can get and afford primary care, and so that people with insurance have a place where they can go for primary care. Remembering, insurance is not primary care. Marguerite is primary care. But we need somebody who's in charge of this process. And that someone at the end of the day is you. Nothing happens in healthcare until communities assume the responsibility of providing primary care to everyone. And no community will do that unless you step up and start or join a local work group in your own community. So let's get started. Send me an email and we'll get you set up. Now I'd like to reintroduce Larry Bauer, one of our amazing board members, who will talk about how you can support primary care for all Americans and why your help, even if it's only a few dollars a month, is so important. Larry?
Michael, you know, care is the only form of health care that consistently leads to lower spending and better health outcomes. Yet our health systems still fail to guarantee access to this essential foundation of care. Primary care for all Americans is building a grassroots movement to transform that system, community by community, into one that is affordable, high quality, and accessible to everyone, grounded in strong primary care. We are a very lean organization, powered largely by volunteers, but meaningful advocacy is not free. Your support, even just a few dollars a month, strengthens our research, fuels our policy work, and amplifies the voices of people who are too often left out of the conversation. Help us fund this amazing organization, these Zooms, and our events. Connect us to potential sponsors of events like our upcoming convenings in Boston and Nashville. Every contribution brings us closer to a fair and healthier future for us all. So please visit primarycareforallamericans.org and click donate. Any amount helps, and if you are able to give monthly, it makes an even greater difference. Recurring support helps us plan ahead and commit to the long work required to create real change. And the bottom line is put your money where your mouth is. Put your money where your well-being is. Put your money where the good of your community is. Thank you very much for being a part of this. And Dolly, I'm returning things to you.
All right. It's been such an awesome discussion tonight. Thank you all for joining us tonight. In 2 weeks, we'll be meeting again. We encourage you to invite someone new to get involved in this movement. Mark your calendars for February 10th, where we'll be hearing from Dave Chase. You can register on our website at www.primarycareforallamericans.org, where you can also check out our local and state playbook, volunteer, and donate to support this cause. Thank you again, Marguerite, and our facilitators, and thanks to everyone for joining us tonight. Have a great evening.
Thanks, Dolly. Thanks to everybody. Stay safe and warm for those of us who are in the Northeast.
Thank you again. It really was
For
a
everybody.
pleasure. I included my email, so if people have questions, happy to follow up.
Thanks, everybody.